What's laser? Yeah.
I just want to ask you a question when
Sure.
you're ready for questions. I went to get LASIK. I'm really blind.
Right.
And I wear contacts, but I went to get LASIK a couple years ago, and they said, oh, your corneas are too thin.
Right.
So they said, we can implant a lens. Oh, maybe this was 10 years ago when they first started just implanting lenses, and I didn't want to do that yet.
Right.
And I'm waiting for my cataracts.
Right.
Anxiously waiting
Right.
so I can get the lenses implanted.
Right.
So now, does that have any problem if I have my corneas too thin?
Okay, with LASIK, this is a different procedure. So it has nothing to do with the cataract operation. So when you have LASIK, you're cutting a portion of your cornea off to make you not nearsighted.
Okay.
So someone who's nearsighted, your cornea is too rounded.
Okay.
And your eyes too large. Okay, so therefore light's focused in front of your retina, so you're nearsighted. So in order for the light to be focused on your retina, you've got to hold something close.
Yeah.
So if we think that when we do, and we don't think we know, that if you don't leave enough of the corneal tissue thickness there after the laser, your cornea will start warping and won't have enough structure to stay normal. And so if you have so much nearsightedness, and then compared to the thickness of your cornea, then therefore you're not a good candidate for LASIK because you would be at risk of that happening to your cornea. Now there's another way of getting around that, because when you do LASIK, you're making a flap in the cornea. So you're cutting 120 microns, I mean, we're talking tiny pieces, but 120 microns across your cornea. I switched over to a different computer, it finally turned on. So I just need to switch them. So you got 120 microns, and so then you've already lost some structure by cutting through that. So the old original way of doing, it wasn't LASIK, the first thing was called PRK. So PRK was you took the epithelial cells off, which have no real structure, and then you did the laser on top, so there wasn't that cut. So I've done people who weren't LASIK candidates, but we could do them without doing the flap and do the surface the old way, and you'd have enough corneal tissue to do it that way. So that could be, but you may not have enough corneal tissue for that either. I mean, I just don't know.
Well, my question is, so when I go to get my cataracts done, it won't be a problem, because I never had anything done.
It's not a problem.
Okay.
But cataract surgery, we're not slicing through your cornea. That doesn't really matter. Okay, so now the newest thing is laser cataract surgery, and we just did actually a few cases this morning. So basically, it's a sort of, this was made by the company that makes the laser. So basically, what's happening is younger and younger people are having cataract surgery because active lifestyle, you won't vision earlier because you want to be doing all these things. So in England now, they don't do cataract surgery anymore. So if you live in England and you're over age 65, you're no longer a good citizen and not paying taxes, so you don't get cataract surgery over age 65. Wow. If you're under age 65 and you still can work and you're still going to pay some taxes, then they'll get you the cataract surgery because then you're still a productive citizen. But stay tuned because that's coming here.
Yep.
So, like I said, everything is changing, and so now this laser is just the baby boomers and everyone who's now getting towards the cataract age. We're all, iPhones. We're all changing our technology. So now this is another step up in technology of doing cataract surgery. And so what are we doing with this laser? So this femtosecond laser that's used for cataract surgery was also being used for making the flap in LASIK. That's where it first started about 7 or 8 years ago. Before you made a flap with a machine, now it's been done with a laser. And what's femtosecond? That's 10 to the 10th of a second. So a lot of zeros of a second that the laser is on. So it's multiple short little blasts are, trillion millionths of whatever it is of a second. And that's a femtosecond laser. And it's extremely precise because it's isolated just exactly where it's aimed. And it's of extremely short duration, so it doesn't disrupt other tissue. So there's different kinds of lasers. Everyone thinks of a laser and it's going to burn something. Well, there are lasers that do that. And so when a company is deciding to do a particular procedure, then different wavelengths of light have different properties. So a laser is a focused beam of light of one single wavelength. So you choose different wavelengths to do different things. And so the first lasers were chosen because they would cauterize or burn something, and they were a certain, and different wavelengths had certain slight different properties. This laser is of a wavelength that is a cold laser. So it doesn't create any heat. It is a precise cutting machine with no heat. And so so a laser is just a focused beam of light of a specific wavelength, and each wavelength has different properties. So basically what we're trying to do is by adding the laser to the procedure, the theory is we're going to get more consistent results, and we're going to, people who want to see well without glasses, we're going to be able to more predict exactly a better result every time we do this. And so that's where the company who's making these lasers is promoting consistency and safety in the procedure. So the biggest part is what these are the things that the laser will do, and we'll go over that. But it will make a corneal incision, and it will do what's called a capsulorhexis. And then it also softens the lens inside there that's become a cataract to soften it so it's easier to get out. And so basically, this is going to reduce, by doing it with a laser, those things. The incision part is really something they're sort of the company promotes because the incision's easy to make. I mean, there's nothing, it's anybody, any average surgeon can do the incision. There's nothing special about that. The capsulorhexis is a lot more difficult to do well. And so when a resident is doing this and learn how to do it, depending on which study you look at, up to 20 to 25% of the cases they mess that up when they're trying to train. So, so if someone wanted to go to the VA and let a resident work on their eye, they're free to go do that if that's what they want to do. So what does this do? So basically, we're able to do, not only is there a laser in this machine, but there's also sort of like, you know, what you would know like a CT scan. It's not a CT, it's an OCT. But for what you can understand, a CT scan of your eye. So this is the scan you can see up here. So this CT scan, this is your lens inside your eye behind. Here's your iris that's been dilated, and here's the lens. And this is the area in yellow that the laser says it's going to treat because it's going to stay inside of this capsule so it wouldn't tear that capsule. This is where the corneal incision is made, and it's a three-plane incision. When you do incisions, typically, most of the time with a blade, it's a single plane, but it's making a three-plane incision, which is more watertight. So we don't put stitches in these incisions. They're 2.2 millimeters in size, and they don't require any sutures. And then also, this is centering the opening that's made in the capsule right in the middle. So this is precise control by the laser. And this is what the machine looks like. So there's actually a monitor, two monitors. This is pretty much the control monitor that goes into the computer. This is what I see through the microscope in the machine. And then the laser is inside here, and there's a light pathway, and then the laser goes down right there. And so this is what I see on that screen when we do the surgery. So we're lining up all these things on your eye. So this is the incision that's made by the laser, and this is 2.2 millimeters in size. There's also a little tiny side incision that's made because the second instrument is in the eye to do the surgery. And then all these different things, these are incisions for astigmatism. So if you have some astigmatism, like I said before, astigmatism is your cornea is shaped more like a football than a basketball. So on the steep side of the football, you can make these little incisions that let the cornea relax to make it round like a basketball that gets rid of your astigmatism. So these can be placed anywhere I choose to place them around the eye. So if the astigmatism is over here, I put the incisions there. So that can be moved. So this is your cornea. So the clear part of your eye, this is a OCT of your cornea. So we're making sure that your lens is surrounded by a capsule that's sort of like cellophane or saran wrap. It's that sort of thin and fragile, and so we manually put a 5mm opening by hand. Most of the time I do it manually. We now have a machine that does it exactly 5mm. So this laser is saying we're going to start cutting this far below the capsule and that far above. So we cut all the way through the capsule. So that's the plan. So I make sure that everything's within sight of these two lines. Same thing with the laser doing the cutting inside the lens. I make sure that it's far enough away from the posterior capsule that you wouldn't rip it, and far enough away from the anterior capsule. So all this, once this is all acceptable, then that's when the laser is actually turned on. And this is a electron micrograph of what the incision looks like after it's healed. So there's no stitch that's needed to heal that incision. So this is another thing that we're putting a lot of emphasis on, and why this is a better way to have your cataract surgery done is an effective lens position. So what that means is that by that little circle that's made in that capsule in the front, that's 5mm in size, the laser makes it identically the same every time. A good surgeon's pretty good at doing it. A mediocre surgeon's sort of average at doing it. And so by doing that, where the lens sits in your eye determines the result of what you see. So if you pull your glasses out, you don't see well, right? So if your glasses aren't in the right place, when we make glasses, it needs to be so many millimeters from your eye for you to see right. So if that lens moves out or back, then it blurs your vision. So inside the eye, it's even more magnified because this is a strong lens inside your eye. So if that lens moves 1/100 of a millimeter frontwards or backwards, it changes the result of how well you see without glasses. So the theory is that by having everything always the same size and everything centered perfectly, that will be consistently sitting in the same place every time. And so that's, like I said, where they're putting their emphasis. And this is just a diagram showing that. So this consistent capsular rhexis opening in that capsule is an important part of the operation. This is still early on, so we don't know what exactly the numbers are going to be. I'll be quite frank about things, is that the doctors who've done the first studies on this are being consultants to the laser company. So you have to, anything that studies says X, Y, Z, you got to know who's writing the article and what the background is. So I think what they're saying about this is true. We just don't know how big of an effect when there's a lot of doctors who start doing this as time goes on, because there's still very few of these lasers around. So, also the laser, your lens, the central part of the lens is somewhat dense. It's not like a concrete, but it's somewhat dense. And so the laser is able to make patterns in this lens of different kinds that I get to choose what that pattern is. And by the laser doing this, that means there's less ultrasound time I'm using to remove your lens. And so the power reduction in one study was 50%. So the amount of ultrasound power, that's what I'm saying, that this laser isn't a poof and it goes away. It does these different parts of the procedure, but we still have to put an instrument in the eye that is an ultrasound that dissolves the lens up and aspirates it out of the eye. By using the laser prior to that, it reduces the amount of ultrasound time, which can damage cells of the eye, by half. And the other part is you can treat the astigmatism. When you make an incision for astigmatism by hand, it's not going to be as good as this laser making it exactly the size and depth you want to do it. So it's more consistent on correcting the astigmatism as well. And so I can probably show you just a little bit of what it looks like live, and we'll cut it short before they start doing the surgery. We don't want people passing out or okay, so this is a doctor doing a procedure up in Chicago. We're going to turn it off before it gets to the surgery part. If someone wants to watch it, you can stay afterwards and I'll be happy to play. So this is the machine. This is the little device that attaches to your eye. So if you had LASIK or any kind of procedure, the laser is so precise, we can't have your eye moving around while that's doing microscopic little things. So this little device is actually a little suction ring, same thing for LASIK, that attaches to your eye so your eye can't move while the laser is doing what it does. So this, he's just going over that. But you can see up here, this is eye, you can see this attaches to the eye.
Is the patient awake?
Yes, you can see the eye moving a little. You really don't see much. The only thing you see are the lights in there. So this is measuring the eye. So you can see here's the eye, this is the section being applied. And so now these are the incisions that he may change or move around. He's centering everything. He can move the incision wherever he wants to move it. And he can center where this capsulorhexis is going to happen. And then I'll let you watch the laser and then we'll turn it off. So now we're doing a scan. This is like the OCT, this is like the CT of the eye. This is your cornea. He's going to make sure this all falls within the line, that this is all within what he's comfortable with, or where this is going to do the chopping of the lens.
You're taking that section out, is that it?
You're taking the whole lens out eventually.
Okay.
You're taking out pieces,
Yeah.
and you're emulsifying those pieces.
Okay.
So this is going to chop it up into pieces, so you can take it out in a piece, because the lens is bigger. The opening is 5 millimeters, and your lens is 10 or 12, 11 millimeters in size. So you have to take it out in pieces. And an ultrasound does that. There still has to be an ultrasound that goes in to do that.
What's the amount of pain during this?
None. So here's the laser cutting the capsule in a circle. There's bubbles that come from the laser. This is making the cuts in the lens, and then it's going to make the incisions. So the bubbles are a result of where the laser is going off, and you'll see it make the lens cuts here in just a second, then we'll turn it off. So all these is cuts inside the lens to soften it up, so all the ultrasound time is less. There's the incision. Here's the incision. This is the primary incision, and then the secondary incision. And that's it. So we'll turn it off because you don't need to watch the rest of it, unless someone wants to.
Then you implant another lens?
Yes. So then that's in one room. So then you get wheeled out of that room into the regular operating room where the other equipment and machines are that then actually do the removal. So a ultrasound tip that is, because this is going through a 2.2 millimeter incision, is then put in the eye, and the tip vibrates 45,000 times a second. It emulsifies the lens, and it's already been chopped up a little bit with the laser, and then it's a tube. So then there's a machine that has there's fluid going in, and it aspirates the lens material, and then all the lens material is removed, and then the lens is put back in that same capsule that held your own lens. And so the implants are like, you can roll them up like a pancake. So then through an injector that's a tube, you put that in the eye, and it opens up inside the capsule, and then that's done. There's no stitches, you're done. Then the next day you wake up and it's like, okay. This is great. So that's what the laser. Yeah.
Is that why it's called a fragmentation? Because you take take bit by bit out?
Well, it's called fragmentation because it's cutting it in pieces. The machine, the actually phaco machine is called phacoemulsification. So it's emulsifying your lens with ultrasound. The laser can't remove anything, it's fragmenting the lens into sections. So then when we go into ultrasound, those pieces can be removed one at a time.
How long have these these types of machines been around?
This laser just got approved 4 months ago.
Oh, so it's real.
Yeah, brand new.
Oh.
4 months ago, there may be 100 of them in the United States now.
How many have you done?
We just did 3 this morning.
And you don't really know for sure on the results.
Well, the surgeries went great. I can't tell you, is this going to make exactly the prediction of the same lens? We do there's a lot of measurements we didn't get into. So before you have surgery, there's lots of equipment that examines your eye, and it comes up with a lens power that all this equipment says is going to give you the least amount of glass prescription. And so then, and the machines we have are very accurate, but there's still a little play. I mean, you're not always going to be exactly 0 prescription. You could be 1 click or 2 off of being 0. But I would say, and Ronnie here is my technician, does all the surgery scheduling as she has system in surgery. Probably 75% of people are 20/20 the next morning. Unless they had astigmatism that they chose not to correct. Because what I told you about a regular plain simple lens is covered by Medicare and insurance. The astigmatism lenses, the laser, all these other specialty things, and the bifocal lenses are not covered by Medicare or insurance. So you are choosing, just like if you chose to have a LASIK to correct your vision, you are choosing to change how you see, and be quite honest about it. This is a one-time deal. You don't go back and change the lens out. So this is a one-time choice. So this is vision for the rest of your life that you're choosing. A hearing aid, they break, you got to replace them, and that costs $3 or $4 grand, and you're changing. This is a one-time thing. So when you make this decision, you want to make sure you get all the information you can get, and you make the best decision for you. And we have equipment that measures how many aberrations you have in your vision system. Even someone with 20/20 vision and no glasses has aberrations in their vision system. If we didn't, we'd have 20/0. I mean, we'd have unbelievable vision, but everyone's cornea, lens, it's not perfect. And so 20/20 is what we consider normal, but you could be super normal if all the aberrations were gone. So the machines can measure all this stuff. Yeah.
Does Medicare pay for the laser part?
No.
They don't.
So they don't pay for it because and you're going to get the true part here because you're not going to get the story, but Medicare will not pay for the laser because the code for doing your cataract surgery says removing your cataract by any means. It doesn't say with a laser, with this, or with that. So by law, I cannot charge you for doing the laser that costs $500,000. So the only thing I can charge you for, so you can have it done with a laser, is tweaking your astigmatism and trying to get you the best vision without glasses. So if you're someone who says, I want to have the least dependent on glasses, and I want to get the best result I can have a chance of getting, then you can have that done because we can put the little spots in your cornea to make sure the cornea is as round as we can get it. And that's what you're paying for. You get the benefit of having a laser do that. But there's no code for using a laser that insurance is paying. Yep.
Does the surgeon's correction of astigmatism complicate his ability to have you see up close and far away, no glasses?
Yes, so if you have a lot of astigmatism, then you're probably not the best candidate for that Restore or our Technis multifocal because you're going to have difficulty getting rid of a lot of astigmatism. So my definition of a lot of astigmatism may be different than your definition because I have people kind of say, I got a lot of astigmatism when we check them and I got almost none. So people get told, you got an astigmatism, and you really don't know how much you have to. Someone really examines and tells you. But yes, A lot of astigmatism with a bifocal lens is a problem. Now, I have done people with a lot of astigmatism, but I've told them up front, this is a problem. You are not going to see good right that time, and we're going to have to tweak around and do some procedures in the office to try to straighten out your astigmatism. And as long as you understand that and you're willing to know that this is what the process is, then I have done people with a lot of astigmatism and we've gotten them happy, but it's taken sometimes 2 or 3 or 4 procedures in the office to get them there. Now in Europe, that Restore lens comes with an astigmatism correction in it. It's not approved in the US yet, but it is overseas that they do have that. I don't know how well it's working because the Restore lens has been around a long time, and the astigmatism lenses without the bifocal have been around a pretty good while now, so there must be something with the astigmatism and the bifocal that the FDA is still not happy about because they haven't approved it yet. Yeah.
You said by the next day we'd be able to go back to work or
Yeah.
do whatever. Are there eye drops or something?
Yes, so you're on eye drops 4 times a day for a week typically, and a couple of times a day for a couple of weeks, thereabouts. Yeah.
So the Restore lens isn't perfect? Is there something coming down the pipe that's going to be better?
There's probably 30 lenses in the FDA studies and trials, and some will make it through and some won't. There's another one coming out that at least the company thinks it might be available in 6 months that is more like the crystal lens that moves and focuses. They're saying they are getting more movement than the crystal lens got, so the focusing is a lot better. So theoretically, that would give you a little better distance, you know, because it's only one power. It would be clear distance vision, not the rings. But, you know, the company will tell you anything because they want you to use their lens. So I don't know. There's some other lenses that do slightly different things or similar to Restore. They're still going through studies because other companies want to have a product to compete against them. And so, but there's nothing I'm going to tell you is going to come out tomorrow or in the next few months that's going to be any different or dramatically better. I haven't heard any research that says we have the lens of the century and this is coming out. I have not heard that. Friday, anybody, friends or anyone who's doing research, and I've done research on lenses. I mean, I've done studies for the FDA on new lenses, and so I haven't heard anything that's special. There is one that's coming out that might be a little interesting. It's not a bifocal though, because those ridges would be removed. But there is one lens that you can apply not a cutting laser, but a light beam and change the power of the lens once it's inside the eye. So if you're slightly a little nearsighted or slightly a little farsighted after the surgery, it could tweak that a little for you. So that's interesting. But we're so good with the equipment we have, I don't know how useful it's going to be because we're pretty close already.
You ever do monovision?
You can do monovision because it's just a lens, so you can do monovision. So I wouldn't recommend monovision unless you sort of worn contacts that way and are happy with it. But you can do monovision. Yeah.
How is the emulsified lens material removed?
That tip is a tube, so there's an opening in the metal. So there's a machine that has a suction device that aspirates once it's emulsified, it aspirates it out of the eye. So the biggest thing is that don't let anybody tell you that you have to have cataract surgery. I've had several people from the church here who've been scheduled for cataract surgery who don't have any. Actually, I won't say who, but one of the pastors was told he had to have cataract surgery, didn't have any cataracts. So it happens. And so if you're not having trouble with your vision, you shouldn't be having surgery, basically.
So the first step is to have an appointment.
Right.
You come in and you evaluate whether you really need cataracts.
Well, I almost tell no one they need it. You're going to tell me I want it because I'm not happy with what I see.
What's the difference between the lens that you have one lens for distance and one lens?
Nothing, just the strength.
Up close? Well, 2 different lenses. Can anybody wear those, or how do they compare to the bifocal lenses? Because you have a choice when you get
Well, if people have worn monovision with their contacts and are happy, there's no problem with doing monovision with the implants. It's the same thing. When you're wearing a contact, it's a strong contact in one eye and not such strong in the other. You can do the same thing with the implants. It's the same process.
So the first step is to have an appointment.
Right.
And then you
And so you have to decide, when you have monovision, you lose depth